Hi, this is Brandy Babin with another Mana Health Partners educational series video. This one's on falls and falls documentation. I hope you like my PowerPoint. I found one with dinosaurs on it. I thought it was really cute, but really a good fit for falls and falls documentation because as extinct as the dinosaurs are, it would be nice to have extinct falls, trying to figure out how to get rid of the falls so that we can get rid of the falls documentation that goes along with it. So here we go. Why do we document falls? Why, as nurse practitioners, do we document falls? Well, first of all, we've got ACA. Second of all, we've got litigation. And then we want to tell a story in the chart of what's going on with a patient. So nursing home falls often lead to lawsuits alleging negligence, inadequate supervision, or violation of federal laws. So we want to be there and protect the patient. So how to reduce litigation risk? So if there's a failure to assess and prevent falls, you've got a litigation issue. We do, as facilities, fall risk assessments on admission and then every 3 months. And that if a patient falls, then we do it again after a fall. So I think we do a very good job, most facilities, in doing fall risk assessments. The question then becomes, have we implemented necessary precautions? Were there precautions in place? And then the lack of documentation in the care plans is a big deal. That's on the facility side. Or failure to follow physician or nurse practitioner recommendations. So that's a big deal. If we're making recommendations, we should be following up to make sure that they've done it. If we say have therapy, evaluate them, we want therapy to evaluate them, and we want to go back and check that that was done. If we say we want a bed alarm on them, we want a bed alarm on them. If we discontinued it, then it should be discontinued. But if we say we want it there, that's our job to go back and make sure that it's there. Negligence and staff accountability. Some examples would be staff not responding to call lights, patients being unsupervised, or failure to provide assistive devices. Now, failure to follow physician orders or nurse practitioner or physician's assistants is a big deal. So if we've ordered physical therapy, occupational therapy, bed alarms, and the staff fail to follow through, it can be seen as negligence. So again, if we're ordering something, we want to verify, trust but verify that what we've ordered has been put into place. Improper post-fall response. This is really what this whole video is about making sure that after a fall, we are responding to the highest level of care that any other provider would in our area. So we're talking about everywhere in the United States. Would a nurse practitioner in a nursing facility do the same exact thing? That's a fall response. So inadequate documentation is what backs up that we did the right thing, but inadequate documentation or failure to assess a patient after a fall can worsen the legal exposure. And then in wrongful death claims, if a fall results in severe injury or death, families may file a wrongful death lawsuit. So remember, if they get pulled into a lawsuit, we'll get pulled into a lawsuit. Have we documented falls in the past? And have we done a good job at assessing the patients and why they fell the first time, second time, etc.? So post-fall medical evaluation. So this is medical, not what the nurses document, but what we document. So we're going to document any injuries, so any fractures, any head trauma, bruising, skin tears. We're going to document any confusion, dizziness, weakness, or loss of consciousness. You've got an alert and oriented patient. You've known them for 3 weeks, and now all of a sudden they can't remember how they fell, why they fell, what they were doing when they fell. That's a big deal. We've got a change of level of consciousness. Any abnormalities in vital signs, maybe that's what caused the fall. So any kind of hypotension, if they're laying on the floor and their blood pressure is 100/60, what are the chances when they got up that it was probably lower than that when they stood up, especially if they stood up too fast? Any kind of tachycardia, even bradycardia could help a patient or increase the risk of a patient falling, or oxygen desaturation. If you're satting in the 70s, if you're having a hard time breathing, shortness of breath, any of that would make it more likely for a patient to fall. Any underlying medical conditions? Did you assess your patient to see if they had a stroke, if they had weakness on one side versus the other? Any signs of dehydration when you evaluated them for skin tears? Did you notice that their skin was tenting, or that they had pale mucous membranes? Any kind of infection going on. We tend to obtain urinalysis every time a patient falls to rule out a UTI. But what do we do about somebody that has increased confusion prior to the fall? Are we looking at thyroid? Are we looking at other indicators that could potentially cause a fall? What if they have an infection? Are we doing a CBC a day or two before they fall to see why they've had their change of mental status? And then we're going to review their medication. So anything that will increase their fall. So sedatives, antihypertensive, diuretics, again, looking at their vital signs. You can be looking at stuff like Xanax, new psychotropics, increase in psychotropics, increase in a number of medications, alpha blockers for BPH that are given in the morning and not at night, Remeron that's given in the morning and not at night. So some of those medications are a big deal. And so doing a thorough and complete medication reconciliation, you'll hear me say this over and over again, no matter what I'm talking about, whether it's weight loss, whether it is a fall, whether it is a new admit, medication reconciliation is huge. We are ultimately accountable for the medications that the patients take. So when they're taking 3 or 4 medications, look them over. When they're taking 25, we've got a lot of meds on board. So we need to really do a thorough job of medication reconciliation. So this says physicians. So physicians or physician extenders, nurse practitioners or physician's assistants should provide a clear, detailed documentation to ensure proper patient care and to protect against regulatory or legal issues. So what needs to be included? The immediate fall assessment. This is critical to do as soon as you find out a patient has fallen. So if they fell on Sunday and you're here on Monday, you should be evaluating that patient on Monday morning. You should not be waiting until Monday at 5 and then find out that they decompensated and now they're going to the hospital and they end up with a subdural hematoma. So immediately, as soon as you find out, you should be doing that assessment. The date and the time of the evaluation. So maybe you didn't get to chart it until 8 o'clock that night and you were evaluating the patient at 7 in the morning. That date and time of that evaluation is critical. Any symptoms that they have, if they're able to communicate, findings from physical and neurological exams. And then are there any medical causes or risk factors that we identified prior to them falling? Was the fall due to a medical condition? So we've talked about syncope. We've talked about orthostatic hypotension. We haven't talked about neuropathy and the numbness and tingling that goes along with the feet. And maybe there's pins and needles and they stand up and they collapse to the floor. So those things should all be addressed as we're discussing falls. Anything new, anything going on with a patient, anything that's getting worse that we need to look at, or any medications that may have contributed. So treatment plan. So we're definitely going to want to do an X-ray, a CT scan, any lab work if anything comes up of significance. We're going to adjust medications if needed, if we see something that may have caused the fall. Therapy referrals, so physical therapy, occupational therapy. And then fall prevention recommendations. So whether that's assistive devices, whether the patient's not been drinking very well because they've been sick or nauseated, and getting them to increase the hydration, whether they need help holding the glass. Some of that stuff is really what we need to emphasize to the staff that this is a big deal. And then vitamin D and vitamin C supplementation as well to make sure that we don't have degradation of the bones. So we don't want to see osteoporosis. And so vitamin D supplementation is a very important part. So how do you know who fell? Like you need to come in the morning and we're going to see the patient. So in point click care, we're going to go immediately to the incident details by going under risk management. So you click the clinical tab and you come down to risk management. When you open up risk management, you're going to see this line and you're going to want to see the active risk management. So those are all of the current things that are going on, not a summary, not the historical, but active. You're going to scroll to the bottom of the list and you're going to find recent falls. So anyone that you haven't documented on, everyone that's had a fall over yesterday to today, the day before that, anyone that has had a fall, we need to work up. We need to look at them and make sure that there's no issue with that. So how do you get into that note? On the right-hand side, on the left-hand side, there's the edit and print. If you click onto the edit, you're able to look at the note. And so you'll see the nursing description, and under it, it'll say nursing description, and it'll write what the nurse said happened or what it was reported happened. You'll also see a resident description right underneath that. It might be blank. There's a little box that's checked that patient doesn't remember or is unable to communicate how they fell. But if they did tell you how they fell, it would be here in this box, and nursing would already have documented that. And then at the very bottom of that is a section that includes actions taken. So immediate actions were taken. While there was probably going to be an assessment, they were probably assisted back in bed. There was probably a call light that was placed on them, clipped on them, put in their hand. So you'll see the immediate actions that were taking place. The assessment of the patient. So vital signs, again, we're going to look at that, and we're not necessarily looking at the vitals from yesterday from the fall, although today's vitals are good. If yesterday's blood pressure was low, that's what we should be focusing on. And then what are we at today? Are we better? And then potentially, did those vital signs yesterday cause that fall? Level of consciousness when we're getting to the assessment, the mobility, so the ability to move, to bear weight. You can put range of motion within normal limits if it is. If they've got external rotation, document that. If they have hemiparesis, you can put range of motion within normal limits for patient, WNL. So it's within normal limits, but not really. It is for the patient because they have the hemiparesis. Any neurological assessment. So if they hit their head, neuro checks should be done. So you should go to the nurse's station and ask to see the neuro checks. You should be looking to make sure that they've got the neuro checks and that they've been started, and looking at that blood pressure, looking at their heart rate, to make sure that they're not having some kind of a bleed. We're looking for bruises, lacerations, fractures, head trauma. Sometimes bruises don't happen on the minute they fall, and maybe even an hour later. So maybe the next day you see a bruise that wasn't there yesterday. Well, it does take time to develop, sometimes not a lot of time, but you might find bruises that they had not documented within 2 minutes of the patient falling. And then any pain or location of pain, and all of that needs to be included in your documentation. So I've tried to make it easy. We've got a fall snippet. It's under the HPI, and it's basically a blank, fill in the blank. The patient had a fall, nursing reports, Cognition is, at this time, the skin is, the musculoskeletal is, the cognition. And so there is a snippet. You just click fall snippet under the HPI, and this is what pops up. So we're going to go over snippets again because snippets are a very big deal. I do not want you just clicking a snippet and then leaving it as is. This is as important as advanced care planning. This is as important as your tobacco cessation. Snippets needs to be adjusted. So a snippet, that's what we call it in our computer system. A snippet or a dot phrase is a short, pre-written piece of code or text designed to convey specific information. And it's either in a template or it's in a statement, a sentence, two sentences, paragraph form, and it is just a brief, concise statement. Now, that statement is not the same for every single patient. The snippets are intended to be adjusted, edited, and customized. This is not a one-size-fits-all scenario. So customize based on whatever the context is or the individual needs of the situation. So this is not a universal template. In fact, it's very empty and blank, whereas some of your other snippets, you're going to delete a whole bunch of information. This one, you're going to fill it in. And if you can't remember what to fill in, I've given you that template where you can fill that stuff in. So templates have been made to include multiple answers sometimes with the intent to delete what is not applicable, and then your statements are correct. So you've either got a blank template, a template that's filled in that needs to be deleted, or you're going to customize the snippet. But again, snippets are intended to be adjusted. Fall risk assessment and prevention. So what is the history of the fall? Was there anything that contributed to it? And so some of this stuff we may know, and some of the stuff the staff may know, but you always want to go in and as you're assessing the patient, whether it's a day or two later, they fell on Friday night and you get there on Monday morning, you're going to be looking at medications, medication reconciliation. You're going to ask the patient if they've had any dizziness, any vertigo, any lightheadedness. And then you're going to do an assessment. You're going to look and see if the patient is a hoarder, if their room is cluttered, if they have poor lighting, if there's stuff everywhere. You're going to provide education to not only the patient, but the staff on fall prevention strategies. So discussing with the patient is just one more person reiterating they cannot get up without assistance. They have to use their call light. Where is their call light? And then have them show you where their call light is. Now have them push the call light so that they can do a return demonstration with that. And then any changes in care plan will be put on the patient's care plan and point-click care, but then also we would count that as well. So recent fall, the patient had a recent fall. What is the date of the fall? Patients at high risk for falls and likelihood of need for admission, PT and OT to assess balance and gait, reviewed medications and reconciled to rule out medication side effects. And then vital signs were reviewed to evaluate any hypotension or bradycardia, blood pressure log reviewed, blood glucose log reviewed, and then coordinated falls. So all of this is part of your fall assessment and plan. This is going to be at the bottom, and this is going to be a snippet as well. So you're going to click the fall snippet under assessment and plan, and that's what this looks like. So you've got two separate snippets, one under the HPI that we just looked at, and then one under the assessment and plan. They may look a little bit alike, but they're not. One is telling you what happened, and one is telling you what the plan is going to be. You reviewed medications. You reconciled medications. You looked for side effects. And then there's no medications that you're going to discontinue at this time. They're all appropriate. Yes, the patient is on diuretics, but needs it. They have congestive heart failure. You don't have to explain every medication, but if you've looked at the medication and it's appropriate, then we're going to keep that. So here's an example of an HPI. So here on the left is your snippet. It's just basically the patient had a fall, and then you fill in the blank. And then nursing reports that patient, and then you fill in the blank. So this is your blank snippet. You click fall, and this is what snippet comes up. It's very easy to fill in, and then you don't have to remember what you have to document. So here's my example of using this snippet. The patient had a fall on 1/1/2021. I know I'm behind a little bit. And then the nursing reports that patient, and this is where I'm going to get it out of the risk management, was found sitting on his bottom on the floor. At this time, patient's skin is bruised, lacerated, skin tear, abrasion, whatever it is. I wrote clean, dry, and intact without, and I'm making sure I specify that there's no other injury. I'm not just saying their skin is clean, dry, and intact, but I'm also saying that they don't have any skin tears, they don't have any abrasions, or they don't have any bruises. So I'm going to define that skin, what it is and what it isn't. Again, we're in the history of present illness. We're at the very top. So I want to say positives and negatives. No skin tears, no abrasions, no bruises. And then the musculoskeletal system is within normal limits. Range of motion within normal limits. If you had any external rotation, if you had any thing that was abnormal with your musculoskeletal system, you would put that here. Cognition is, and you can put it baseline. You can put it baseline and confused. Confused and at baseline. Alert and oriented and at baseline. Cognition is intact. So put something, but you've got the colon here. Cognition is colon, then fill in the blank. And then injuries. No injuries noted. Why is that important? Because in a week, if they've got a swollen foot, did that come from the fall? Probably not a week later, but we want to specify that we looked to see if there were any injuries and we didn't see any. There were no injuries at the time of the fall. And then no complaints of pain or discomfort. Now, we do have a lot of patients that are on Loratab, Oxy, Dilaudid, fentanyl that do have chronic routine pain. So you could write something like patient denies any increased complaints of pain or discomfort related to falls. If you've got a patient whose normal pain is 8 out of 10, or 6 out of 10, whatever they tell you it is, and they're on around the clock pain medication. So you're obviously not going to say denies no complaints of pain. They've got some, they're always going to have some, but you could write patient denies new complaints of pain or any increased pain related to fall. And then discuss with patient to use call light and wait for assist prior to getting out of bed. That should be W. Discussed with nursing regarding frequent checks. Notify MD or nurse practitioner of any change of condition. I'll have to check the snippet. The patient continues to be at high risk for falls related to diagnosis, poor safety awareness, impulsivity, recent falls, and weakness. Now, I want you to know that that is a snippet. That's part of the snippet. So you will have to adjust it if applicable. If the patient does not have poor safety awareness, they're alert, they're oriented ×3, they know to use the call light, they know to transfer independently, it was a fluke fall, whatever it was, delete that out of there. If the patient is not impulsive, then delete that. But if they're impulsive because they have a diuretic and they got to get to the bathroom and you have 1 minute from the time they put their call light on to get them in there and they can't wait and they're impulsive, then keep that in there. Recent fall, obviously, and then weakness. They had weakness, they fell. So if there's anything else you want to put in there, you absolutely can. If you want to put diagnosis of hip fracture, of dementia, of cognitive impairment, add that. But again, this is part of this snippet which means that should be adjusted if there's a change. Now we're on the bottom. We're at the assessment and plan section. So on the bottom left is your blank snippet. That's what you're going to adjust and alter. This is my example. So this is the snippet and this is the example. So recent fall, January 1st, 2021. Patients at high risk for falls and likelihood of need for admission or transfer to the hospital if injury noted. Well, if they're not at high risk and this was a fluke, then you can delete that out of there. But if they had a fall, they're probably at high fall risk right this moment. So maybe for the next week, they're at risk for falls because they had a fall and we don't want them to fall again. PT and OT to assess balance, strength, and recommend modalities to improve coordination and strength. Reviewed, and this does not say review. This says under your assessment and plan, you reviewed medications and you reconciled them to rule out medication side effects that may cause hypotension, dizziness, altered mental status, or drug-to-drug interactions. So you have done that. It's not for someone else to do. It's not that you're going to do it, that you actually reviewed medications. And then all of the medications are appropriate at this time and you're not able to discontinue any medications. Vital signs were reviewed to evaluate hypotension or bradycardia. Vital signs could be including a temperature, if you wanted to add that to the snippet, or O2 sats of 72%, put oxygen on, that sort of thing. So don't feel like you have to just use my snippet. It's just a guide for you to add to it. Blood pressure log reviewed. It was normotensive, but they had 3 episodes of hypotension this month. Will obtain orthostatic blood pressure ×3. Again, we're still under the assessment and plan. What was our assessment? They had the fall. They're at high risk for falls. And what's our plan? Our plan is for PT and OT to look at them, medications to be reconciled, vital signs were reviewed, blood pressure log reviewed, blood glucose log reviewed. And then I put like what their blood glucoses were between 125 and 172. Because if they had 3 episodes of blood glucoses at 62, 64, and 66, even though it might not have contributed to the fall, that should be a trigger in your head that there needs to be an adjustment to either medications or a bedtime snack, etc. And then you coordinated those fall preventions with nursing administration as well as therapy. So you're going to do that in your morning clinical meeting. Final note, this is what it looks like. So my HPI says the patient fell on 1/1/2021. They were found sitting on the bathroom floor. The skin is clean, dry, and intact without any skin tears. Cognition at baseline, no injuries, no pain. Discussed with patient. I already fixed the DC, and so I'll fix that on the snippet. And then our assessment and plan at the bottom. They had a fall. They're at high risk for falls. You reviewed their medications. Their medications were appropriate. Their vital signs were good. Blood pressure is 122/70. Heart rate is 72. Over the past month, heart rate's not less than 68. Is that a big deal? Yes, it is. Blood pressure log reviewed, normotensive, 3 hypotensive episodes this month. And what else is our plan? We're going to get some orthostatic blood pressures. Blood glucose log reviewed. If they don't have a blood glucose log and they are not diabetic, delete that out of the snippet. And then coordinated the fall preventions with nurse administration as well as therapy. Things that increase falls. So older people have more risk factors for falls, and a combination of those risk factors increases the individual's risks. So that's why our assessment and plan is so very important, is because we can do things that the nursing and nursing facility cannot do. We can reconcile those meds. We can reconcile those vital signs. We can reconcile what's going on with the patient. So any weakness or limited mobility, vitamin D deficiency, vision problems, medications, clutter, Doctors can help decrease the risk of falling by recommending certain medications and supplements. Falls. It's a great subject. It's something that we have a lot of impact on. And I think that as we go through this, these snippets will help if we utilize them correctly. And I hope you got something out of this video. So if you have any questions, again, I'm Brandy. My phone number is down here. My email is bbabin@monahp.com. If you have any questions that you would like to discuss with me or any concerns about documentation, call me, text me, email me, let me know. If you liked the video, click like. If you had questions, let me know. But I hope you enjoyed today's session and have a great